Hello again, it's Dr. Harim Jaffer. Today I will talk about important notes on periodontal pocket. So this lecture will be continuation of the lecture of the pocket. Please subscribe to my channel HL Talent to get more videos. One of the most important notes that we should take into account while reading the pocket is a periodontal disease activity. For many years, the loss of attachment produced by periodontal disease was thought to be slow but continuously progressive phenomena. But more recently, as a result of studies on the specificity of plaque bacteria, the concept of periodontal disease activity has been evolved. And they thought, according to this theory, that the periodontal disease go through a period of inactivity or quiescence and a period of exacerbation or activity. And they say that during the quiescence or inactive period, there will be a reduce in inflammatory response, there will be a little or no bone loss or caul, and the disease is more stable, and the type of bacteria also mostly gram-positive bacteria. So not always the periodontal disease have the same rate of destruction. There will be a period of inactivity and a period of exacerbation or activity. And during active period, there will be an increase in inflammatory response, increased bone loss and clinical attachment loss, and build-up of floating or unattached bacteria. And most of the bacteria will change to gram-negative and motile bacteria, and may last for days, weeks, or months in an active stage. And this stage is followed by a remission. So there's an exchange between exacerbation, remission, exacerbation, and remission. And this is one of the important features of periodontal disease. Second one is site specificity. Periodontal destruction doesn't occur in all parts of the mouth at the same time, but rather on a few teeth at a time, or even only some aspects of some teeth at any given time. And this is referred to site specificity. As you see it here, for example, there's a bone loss here, an attachment loss, but this is just on this tooth, affecting part of this tooth. So there may be localized to one or two teeth, or on the same tooth. For example, this, we have an attachment loss here, but we doesn't have anything here. So this disease have a site specificity. And sites of periodontal destruction are often found next to sites with little or no destruction. So there may be a site of destruction and passed to other site, but there is a difference between the destruction from one tooth to another and from the surfaces of the same tooth between each another. And this is another feature of periodontal disease, site specificity. Another feature or another important note is that we have pulp changes associated with periodontal pocket, and the spread of periodontal infection or periodontal pathology from the pocket throughout the pulp is occurred either through the lateral canals or through the apical foramens. And this lesion we called a perioendo lesion. We have a primary endo, which is the main source of infection, is tooth, then secondary perio, which is then affect the periodontium, and you have the sound tooth, primary perio, secondary endo, which affecting the pulp of the tooth, or it will become a combined lesion. And this is another feature of the periodontal disease. It may not just confine to periodontium, it will affect the pulp also. The other feature, the most complicated feature, I hope you understand it well and you listen well to this feature, because it is somehow confusing, but it's very important, is the bone loss and clinical attachment loss relationship with the pocket. The severity of attachment loss in pocket formation is generally, but not always, correlated with the depth of the pocket. So it's not necessarily that clinical attachment loss is associated with the same depth of the pocket. This is because the degree of attachment loss depends on the location of the base of the pocket and the cemento-enamel junction, which is a fixed point, while the location of the pocket depends on the free gingiva and the base of the pocket, which is movable point and the base of the pocket. What's important here to notice is that an area of the same pocket depth, as you see it here, for example, here it is 3 millim, 3 millim, and 3 millim, the same pocket depth, but you have a different attachment loss. Here the attachment loss is 0 because the cemento-enamel junction is equal to the base of the pocket. Here the attachment loss may be 2 millimeter because from here to the base, and maybe here it is 5 to 6 millimeter the attachment loss. So we have same pocket depth but different attachment loss. And opposite to that, we have, for example, here a different pocket depth. Here it is 0 or 1, here it is 2 or 3, here it is 5 or 6. From free gingiva to the base of the sulcus or base of the pocket, maybe 6. Here from here to here, maybe 2 to 3. Here maybe 0 to 1. But here we have the same attachment loss from cemento-enamel junction to the base of the pocket. Cemento-enamel junction to the base, we have the same. So it's not necessarily to have the same pocket depth and equal attachment loss. The severity of bone loss is generally, but not always, correlated with the pocket depth. So it's not necessarily to have a bone loss in correlation with the pocket depth. Extensive attachment and bone loss may be associated with shallow pockets. If the attachment loss is accompanied by recession of the gingival margin, and slight bone loss may occur with the deep pockets. So this is another feature. The fifth feature is the area between the base of the pocket and alveolar bone. Normally, the distance between the apical end of the pocket or the junctional epithelium and the alveolar bone is relatively constant. The distance between the apical extent, the lowermost part extent of the calculus, and alveolar crest in human periodontal pocket is constant, and it's 1.97 millim. While the distance from the attached plug to the bone surface is never less than 0.5 and not more than 2.7. So this is constant. The attachment of the calculus and the distance between the calculus and alveolar crest, and the distance from the attached plug to the alveolar crest are all of them are constant, and the bacterial challenge will happen between the bone and between these area, between 1 millim, 1.97 in the calculus and 0.5 to 2.7 in the plug, in the attached plug. And while the change will happen, the major changes will happen when we have a floating bacteria or a mass of bacteria on the connective tissue and on the bone. This will make the changes. Otherwise, all of the distances of the calculus and plugs are the same. The other important and last feature is the relationship of the pocket to bone. We have two types of relation. We have infrabony pocket as you see it here. Here the base of the pocket is apical to the crest of the alveolar bone, and the pocket walls, this wall, this is the pocket wall, lies between the tooth and the bone. Tooth and the bone. We have the space of the pocket wall between the bone and the tooth. The bone loss is in most cases are vertical. You find it here vertical and oblique. While in supra-bony pocket, the base is coronal. The base of the pocket is coronal to the alveolar crest, and the pocket walls lies coronal to the alveolar crest between the tooth surface and the gingival tissue. And the bone loss here always horizontal, and this creates a microscopic difference that have some therapeutic importance. In supra-bony pockets, the alveolar crests gradually attain a more apical position, but on the same manner and morphology. It doesn't change the morphology, while here it changed the morphology, and the alveolar crest and the principal fibers between this tooth and the adjacent tooth will be always horizontal, passing through horizontally, while here the principal fibers is obliquely or vertically. And this will give you an idea regarding the loss of the bone and the manner of reconstruction or regeneration. Thank you for your listening. This is the last of this lecture. I hope you get benefit from it.